Good afternoon, fellow doctors and colleagues. I'm Zhu Zhili from Fuai Hospital in Beijing. Today I'll share with you the topic on the electrocardiogram and echo in the evaluation of structure and function of heart in hypertensive patients. First, let's introduce briefly the cardiovascular risks of hypertension. Now, hypertension is a progressive cardiovascular syndrome arising from complex and integrated etiologies. Early markers of this syndrome are often present before elevation of the blood pressure, and its progression is strongly associated with functional and structural cardiac and vascular abnormalities that damage the heart, kidney, brain, vasculature, and other organs. If the target organ damage is demonstrable or the functional precursor of target organ damage is present and still reversible, then reduction of blood pressure will generally reduce the risk for cardiovascular events. This is a chart from the 2016 European Guidelines on Cardiovascular Disease Prevention in Clinical Practice. We can see that the score, which refers to the systemic coronary risk estimation evaluation score, that despite the blood pressure, as factors including the gender, whether the person is smoking, or the level of cholesterol is related to the 10-year risk factors or overall fatal cardiovascular risk of the patient. We can see that both hypertension and left ventricular hypertension are independent risk factors for cardiovascular and cerebrovascular diseases, and left ventricular hypertension will significantly increase the risk of coronary heart disease, heart failure, stroke, and death in hypertensive patients. Before we make the decision to start pharmacological treatment, we should not only make a decision depending on the blood pressure levels, but also on the overall cardiovascular risks. However, even subclinical hypertensive organ damage can predict cardiovascular death independently of the score, and the combination will improve risk prediction, especially in subjects that are at mild to moderate risk, that is score between 1 to 4%. Also, the echo is more sensitive than the ECG in diagnosing the left ventricular hypertrophy and in predicting cardiovascular risk, and may help in more precise stratification of the overall risk and in directing therapy. Also, the 2018 guideline from European guideline for arterial hypertension shows that in patients with high normal blood pressure, that is systolic pressure, blood pressure between 130 to 139, or diastolic blood pressure between 85 to 89, if the individual have a lot of risk factors, including the obesity or insulin intolerance or other target organ damage, they will have higher risk of the cardiovascular outcomes. So, what is left ventricular hypertrophy? Left LVH is an increase in the mass of left ventricular, which is secondary to an increase in the wall thickness with or without the increase in the cavity size of the heart. It's often resulted from the pressure or volume overload. It is more common in patients with pressure overload, which is commonly seen in patients with systemic hypertension or aortic stenosis. For patients with volume overload, which is more common in patients with aortic or mitral valve regurgitation or dilated cardiomyopathy. Other factors that affect ventricular hypertrophy include age, gender, genetic factors, diabetes, chronic kidney disease, obstructive sleep apnea, and dietary salt intake. So, in most articles, LVH is diagnosed with ECG or echo. In a meta-analysis, including 26 studies, we can see that ECG is used to diagnose left ventricular hypertrophy. In patients with hypertension, ECG diagnosed LVH in around 18% of the hypertensive patients. That is including 24% of male and also 16% of female. In another retrospective study on 30 surveys, the authors used echo to diagnose LVH in hypertensive patients, and they found out around 35.6 to 40% of hypertensive patients had LVH, which is 36% to 43% in male, and around 38% to 46% in female patients. The prevalence of LVH in Asia varies between countries. The highest is witnessed in Japan, which is around 40%, and in mainland China, it's about 19% to 34%, and in Chinese Taiwan province, it's around 13%, and in India, it's 24%. So why do we concern LVH? Because it has significance, clinical significance. People with LVH have higher risk of heart failure, ventricular arrhythmia, death following myocardial infarction, decreased LV ejection fraction, and also higher risk of sudden cardiac death, aortic root dilation, and also cerebral vascular events. And the increase in the cardiovascular risk is directly related to the degree of increase in the left ventricular mass. And studies show that for each 29 gram per meter squared increase in the LV mass, there is a 40% increase in the risk of major cardiovascular events. And for each 50 gram per meter squared increase in the LV mass, the risk factor adjusted for hazard ratio for sudden death was 1.45. Importantly, if we can reverse the LVH, the patient will benefit from this treatment and reduce their total cardiovascular disease risks. And in a meta-analysis, including 5 studies with over 3,000 hypertensive patients, it shows that in patients without LVH or have reversed left ventricular hypertrophy, the risk of cardiovascular disease is reduced by 46%. So, who should be evaluated for LVH? In fact, all patients with a definite diagnosis of hypertension should be screened for LVH, because LVH can occur at any period of time after the onset of hypertension, even before the onset of hypertension. And effective blood pressure control will promote or accelerate the progression of LVH. Therefore, patients with poorly controlled blood pressure should be at a priority to screen for LVH. The 3 examinations for left ventricular hypertrophy are ECG, echo, and also CMR. If we consider the practicability or the feasibility or reproducibility of the examination, then ECG and echo are recommended because they are relatively cheaper and they have shorter waiting lines. But if the patient is diagnosed, then CMR is recommended because it can help to differentiate patients with DCM or hypertrophy or HCM. Now, how do we diagnose patients with ECG? In patients with LVH, their frontal plane shows that in leads the R wave amplitude in their leads will amplify. The most common criteria used to diagnose LVH using ECG is the Sokolov line criteria, in which the S wave in the V1 lead and R wave in the V5 or V6 lead, the sum of these, the amplitude of these two waves, if it's above 3.5 millivolts or 35 millimeters, then the patient can diagnose with ECG LVH. There are other ECG findings that may indicate left ventricular hypertrophy, including an increased QRS duration, which may be around 100 to 110 milliseconds. It can be subtle or with incomplete or complete left bundle branch block. Interestingly, in patients with LVBB, most of them will be diagnosed with LVH. Also, patients with LVH may see in their ECG the left axis deviation. And also, repolarization abnormalities are common in these patients, which is characterized by the ST depression and also T wave invergence. So the criteria to diagnose LVH with ECG are as follows. If any of the four criteria is met, then LVH can be diagnosed. The first is the Sokolov line criteria. The second is if the R wave in the AVL lead is over 1.1 millivolts, or the corner product, which is CV, as listed in number 4, the S wave in V3 and R wave in AVL is over 2.8 millivolts in male or 2 millivolts in female. If the corner product, which is CV times QRS duration, is over 244, then the patients can be diagnosed with LVH. We should note that ECG has a relatively high specificity, which is around 80 to 90%, but relatively low sensitivity. In patients with mild LVH, only 7 to 35% can be detected with ECG. And even in patients with moderate to severe LVH, only 10 to 50% can be diagnosed using ECG. Again, people diagnosed with LVH using ECG or echo are strongly correlated with their future outcomes. You can see this blue column here. If both ECG and echo are negative, then patients are at lower risk of cardiovascular risk. If either ECG in the green bar or the echo are positive, then patients can have a 2 to 3 fold of higher cardiovascular risk. If both are positive, then the CVD risk is even higher. Therefore, if both ECG and echo are available, then both of them are recommended. We should note that ECG is more correlated with the electrical LVH, and echo is more correlated with anatomic LVH. It means that in the anatomic LVH using echo, if the echo is positive, we are sure that the myocyte had a hypertrophy, or the interstitial remodeling is present, and if the patient is diagnosed using ECG, we are not absolutely sure whether there are myocyte hypertrophy or interstitial remodeling. However, if the thickness of LV wall is increased by 1 millimeter, then there will be a 2 to 3-fold of increase in the arrhythmia. Indeed, both methods using ECG or echo can predict higher risk of arrhythmia, including atrial fibrillation and also ventricular arrhythmia. So if a patient is diagnosed with LVH using ECG, but in fact he or she does not have LVH, it's called false positive, then which populations have higher possibility of false positive results? It is more common in young adult male, and also if the patient have low body weight, that means the person is thin, or in athletes, then the person will have a higher risk or higher chance of false positive results. And in patients with right bundle branch block or obesity or chronic obstructive pulmonary disease, then this group of people will have higher chance of false negative results. That means they have negative results using ECG, but in fact they indeed have LVH. Echo is another important examination for LVH screening. We can see in this diagram, using echo, we can detect the size of the left atrium and also the size of the left ventricle of the person. This is the right ventricle, left ventricle, and also the left atrium of the patient. We can detect the LVID, that is the left ventricular interdimension diameter, and also the PWT, which stands for post-wall thickness diameter, and also IVST, which is the interventricular septum thickness. If we have all these measures, then we can calculate the left ventricular mass using this equation. And to get LVMI, which is the left ventricular mass index, we divide the LVM with the body surface area of the patient. Then using LVMI, which stands for the left ventricular mass index, if the value is higher than 115 in men or 95 in women, then the person can be diagnosed with echo LVH. This is the Asian expert consensus for diagnosis and treatment of hypertension-associated LVH. So, according to the guideline, if a person is diagnosed using echo with IVST and or PWT, which is the post-wall thickness over 11 millimeter in male or 10 millimeter in female patients, then the person can be diagnosed with suspicious LVH. In the clinical practice, these two measures are usually used to diagnose LVH when LVMI is not available. They can be used as early diagnostic criteria for LVH, but the sensitivity, specificity, and universality of these methods need to be further studied. So still, LVMI is a golden standard for the diagnosis of LVH. So this is the diagnostic pathway for hypertensive patients to diagnose with LVH. First, if a person is diagnosed with hypertension, then they should be evaluated using ECG. If the person is negative when detected with ECG, then they should be followed up after half a year. If the ECG is positive, that is, any of the 4 criteria is positive, then an echo examination is recommended. If the echo is negative, then the patient should be followed up for after half a year. If the echo is positive, then a CMR is recommended for differential diagnosis. Then how should we treat hypertensive patients with LVH? Studies show that in patients with hypertension and LVH, blood pressure lowering will benefit person and lower their cardiovascular risks. But not all 5 types of antihypertensive agents are equally effective in reversing LVH. In fact, ARB and calcium channel blocker, CCB, and also ACEI are more effective than diuretics and beta blocker. Also, the RAS inhibitor, including ACEI and ARB, can reduce LVMI by over 17 grams per meter squared, and CCB by 15. The values in beta blocker and diuretics are around 10 grams per meter squared. So according to the guideline on LVH, in patients with LVH and hypertension, then RAS blocker, including ACEI and ARB, are recommended. If the effect is not satisfactory, then CCB or diuretics are recommended in supplement of RAS blocker. In summary, LVH is defined as an increase in the mass of LV, which can be secondary to an increase in wall thickness and an increase in cavity size or both. LVH is associated with the increased incidence of major cardiovascular events. The increase in the cardiovascular risk is directly related to the degree of increase in the LV mass. And LVH can be diagnosed by either ECG or echo, but echo is definitely more sensitive. The regression of LVH is associated with a reduction in the CV risk and also improved cardiac function. And the reversal of LVH is associated with the use of all 5 antihypertensive agents, including ACEI, ARB, and CCB, and also diuretics and beta blocker. But the latter 2 are less effective than the first 3. So that's all I'm gonna share with you today. Thank you.